you so much for coming on your lunch break. Thank you for investing time in your health. We also want to join with you to kind of help you be able to make good choices and be able to live as healthy life as possible. I'm going to preface this by saying I've been a nurse for 20 years. I am not a professor, and there may be those in the room who could do this far better than I could. So I'd be happy to recruit you for next year. That would be fantastic. But just bear with us that we are used to working more one-on-one with patients. I work with patients at the bedside and with families and that kind of stuff. I am a GI navigator, which helps patients with new cancer diagnoses kind of navigate the process, what's normal, what to expect, and how to get through all this maze of testing and doctor's appointments and that kind of stuff. So again, if we can prevent cancer, then that's absolutely what we want to do. So that's what part of this is going to be about. Okay, so just to start with colon cancer 101. So as you know, the colon is part of the digestive tract. Food goes in your mouth, down your esophagus, into your stomach, into your small intestine, and then ends in your large intestine, also known as the colon. It's about 5 feet or so, and then it goes with the ascending, transverse, descending, sigmoid, and then out through the rectum. That was my Vanna White. I don't know if you caught, okay. So just kind of knowing where the colon is and the function, it helps with absorption of the water and also of some of the nutrients still to get that formed stool at the end. Okay. This is my first PowerPoint presentation because when I was in college, PowerPoint didn't exist. All right, colon cancer is a disease in which abnormal cells in the colon or rectum divide uncontrollably, ultimately forming a malignant tumor. A polyp is a growth in tissue that lines the inner surface of the colon or the rectum. Polyps are more common in people over age 50, which is why we suggested that be the age when people start doing screenings. And again, that's if you have a normal risk. If you are a high-risk person, the screening would start before age of 50, and we'll kind of talk about what makes you high risk a little bit later. Not all polyps develop into cancer. Some polyps will never develop into cancer, but some will, which is why it's important to identify them, find them, remove them, test them, and then that kind of lets us know what the future steps are going to be for monitoring. If you make them, then you could continue to make them. So that kind of changes the trajectory of how we're going to monitor you to make sure that we can prevent this from happening. But most colorectal cancers do begin as a polyp. So it was something that was small that grew and grew and grew into a malignant tumor. All right, colon cancer is the third most common cancer in both men and women behind skin cancer. It is estimated that 140,250 people will be diagnosed with colorectal cancer this year. And these are all statistics from the American Cancer Society that are available for you to view as well. Over 97,000 people will be diagnosed with colon cancer, and over 43,000 people will have rectal cancer. Lifetime risk for developing colon cancer is 1 in 22 in men and 1 in 24 in women. The mean age being around about 62 to 64 years of age is usually when people are diagnosed. That's why we start screenings 10 years before that to try to find things before they can develop into a cancer. It is estimated that more than 50,000 people will die of colon cancer this year, which makes it the second leading cause of cancer death in the United States. So what can you do to prevent this? Well, according to the American Society of Colon and Rectal Surgeons, early detection and removal of polyps before they can become cancerous can prevent up to 90% of colon cancers. This can't be said about other types of cancer, so this is huge. We can actually prevent this from ever happening with proper screening when we can find things early. So there are multiple risk factors. What puts you at risk for developing colon cancer? There are multiple things that you cannot control. You can't control your age, although some of us lie about our age. Not me. We are all getting older, and as we age, you become more susceptible for any type of cancer, including colon cancer. Your race, typically, statistically, it's African Americans have a higher risk. There are other nationalities that have a higher risk, but you can't control how you were born into this world. Personal history of colorectal polyps. So if your body is already able to make and is making polyps, then the chances are you could make more polyps. So that kind of puts you at risk. That means you're going to have more careful screening than if you did not make any polyps at all. If you have ever had colon cancer yourself, the chance of reoccurrence is higher. That colon cancer can come back, or you can develop another colon cancer. A family history of colorectal cancer or polyps. And so to be considered more of a high-risk group, anyone who has 1 or 2 immediate family members, so really if it's one immediate member being brother, sister, mother, father, child, that puts you at higher risk. Or if it's two cancers in the family, whether it's aunt, uncle, grandpa, that kind of stuff, also puts you at higher risk. If you are in that group, typically that does mean they'll start screening you earlier, possibly around the age of 40. Ulcerative colitis or Crohn's disease, all diseases of the colon which are inflammation. So any state of inflammation over a long period of time causes damage to the DNA, which can put you at higher risk for having colon cancer. And last, inherited syndromes. There are two specific inherited syndromes that we think about, one being familial adenomatous polyposis, and the second being hereditary non-polyposis colon cancer, also known as Lynch syndrome. Those account for about 2 to 5% of all colon cancers, but those are very high risk, especially the first one I mentioned. A lot of people will have hundreds of polyps, and those will develop even before puberty. So kind of knowing, you were going to know that though, because it's a family hereditary thing. Other people in the family will already have been diagnosed. So something like that is very rare. However, that does greatly increase your risk of colon cancer. And then type 2 diabetes also puts you at higher risk for colon cancer. So there are things though that you can control. Number one, obesity puts you at higher risk. So being able to control, have a healthy weight puts you at a lower risk. I apologize. Physical inactivity puts you at higher risk. So they recommend at least 3 days a week, up to 150 minutes a week of physical activity will decrease your possibility of getting colon cancer. And frankly, most cancers. It also helps decrease or treat diabetes type 2, which can also be controlled with weight loss and activity. Heavy alcohol consumption, which means less than 2 drinks a day for men, less than 1 drink a day for women, because a high alcohol consumption, again, can cause damage to DNA, can cause damage to your body from inflammation, different things that put you at higher risk. And smoking, we also know inflammation puts you at higher risk for cancers. And then last of all is going to be diet. And my very sweet friend, Sarah, is our registered dietitian. She helps patients who have a diagnosis of cancer and just everyone to help make really good choices about their health. So again, she will go on with that later. So symptoms, what are some symptoms of colon cancer? Number one, blood in your stool. So it's easy when you look down and you see bright red blood. Something is terribly wrong, we should panic now. But what happens is that not everyone can see that blood in their stool, which comes in later with screening. But blood in your stool should always be a warning. That should always be a red flag. You should never go, oh yeah, this is blood in my stool. It's fine. The next thing would be change in the shape of stool. So if you've been, this is fun to talk about poop at lunchtime. I'm really, really sorry. I apologize for that right now. Yeah, put your forks down just for a second. No, just kidding. But if you have been your entire life having a certain size and then that were to change and change consistently, that would be something to keep in your mind as why has this changed? Also abdominal cramping and discomfort that can't be explained by other means. So it's not, an ulcer, it's not something else, it's not cramps, but a persistent pain that cannot be explained. Prolonged constipation or diarrhea, a decrease in appetite, which kind of goes hand in hand with the unintended weight loss. So someone who's lost 20, 30 pounds without trying, has low energy, that kind of stuff. That's just something in the back of your mind to think about. Could it be something else going on? Why is screening important? Early screening can be a form of cancer prevention. We can prevent this, not just early detection. Screening can identify polyps and cancers before symptoms appear. Because again, sometimes you're not going to have those symptoms of the bright red blood in your stool until something is large enough in your colon to get disrupted by food and bleed. Because things are pretty flexible in there and kind of move all the way through. So you're going to have symptoms at a much later stage of this process. One form of screening checks stools for minute amounts of blood. Again, blood that you can't frankly see. So even black tarry stools we think of as having blood, but there are tests that if your stool looks completely normal, there could still be tiny amounts of blood in there because as things pass through your colon and bump up against that, there can just be a little bit of irritation. But again, if it's a very small area that's affected, it's going to be tiny amounts of blood. So again, some tests can check for that. Both polyps and tumors can bleed when stool passes through the colon. The blood cannot always be seen by the naked eye. So there's different types of screening. One would be a fecal occult blood test. This is just a simple test that most doctors do in the office when they do a rectal exam. They just check to see if there's any occult blood at that time. But again, this is just at that time and not reflective of the month, the year, that kind of stuff. The next test is another one that tests for blood in the stool. It's called the fecal immunochemical test, and this one is a little bit more specific in that it can tell if it's human blood or not, because it's possible that if you've been eating raw meats, some of those tests can be falsely positive on the fecal occult blood. The next stool test is called the stool DNA test. This is something that's up and coming. It's called Cologuard. I don't know if some people have heard about it. It does a little bit more to look at the DNA changes. This is also a screening test. However, I know that in some insurances, there is a difference between what your insurance will pay for. If it's a screening test, they will pay, but if it's a diagnostic test, sometimes that's a different benefit. So I know we do have to be careful as far as with insurance coverage, which test is the best for that person. The next is a sigmoidoscopy. This is a test where they, again, put a scope inside, but they only go to the sigmoid colon. So as we discussed, it goes ascending, transverse, descending, sigmoid, and then rectum. So really, you're only getting a portion of the colon, not visualization of the entire colon. Benefits to this are that there's no prep involved, but there's also no anesthesia. It's a little bit of conscious sedation, but there may be a little bit more sensation with that. But it's also, again, only looking at one portion of your colon. So the gold standard, of course, being the colonoscopy. And the colonoscopy gives visualization of the entire colon, the entire 5 feet. So I have one doctor who says there's 2 things he trusts most in this world, and they're sitting right here. Because what you can see with your eyes, you can see a prick on a piece of paper. So when they're looking at a big screen of your colon, and they're looking at it large, you can see very small things in your colon. So again, this is why this would be the optimal test. And if those other tests came back inconclusive or that there is a problem, this would be what you would have to do to be a conclusive diagnostic. During the colonoscopy, they are able to biopsy, to remove polyps, to take pictures, to be able to get those tissue samples, so we know exactly what we're dealing with. And then the last option would be a virtual colonoscopy, which is a type of CT scan that does the same thing. You do have to take a prep, but there's no actual scope in there. But again, if something came up suspicious, you would then have to go ahead and have the colonoscopy, because again, we do have to have that tissue to be able to tell what's going on, where are we in the process, what cellular level changes are there, and does cancer already exist? Okay. So our goal here is, as you can see, is to catch it at the polyp stage. Because if we can catch it at that stage, remove it, then it's never going to progress through the next stages. So the most colon cancers develop from the non-cancerous growth called the polyp. Next is a precancer. Cancer is formed, but not yet growing inside the colon or the rectal walls. Stage 1 and 2, cancer is now growing in the colon or the rectal walls. Nearby tissue is unaffected. So it's all about how many layers through is what determines the stage of cancer. Stage 3 would be growth beyond the colon or rectal walls and into tissue or lymph nodes. And then stage 4, as we know, is metastatic disease. So that's when cancer has spread to other parts of the body, such as the liver or the lungs. And while these tumors look small, what you have to understand is this last tumor is actually completely sometimes obstructing the entire colon. And that's when you get the symptoms. That's when you get the pain and the bleeding and that kind of stuff. But again, we want to find things early so that it does not progress to that level. Oh, I'm sorry. I meant to warn you. My bad. I'm really sorry. So now this is the healthy colon. Put the forks down again. I did go easy on these slides because my husband was helping with it, and he's not a medical guy, so he wouldn't look as I was looking for slides. He would tell me which one, and then he would look at the screen. So I have tried to be kind. So again, this is a healthy colon. As you can see, there's nothing red, nothing bleeding, nothing growing outside of it. And then the next one is going to be a polyp. And as you can see, this is very small, very small. But with the colonoscopy, we can see that. I mean, that's literally not even the size of your thumb. I mean, it's very, very small. But with colonoscopy, we're able to see these things early, identify, remove, and then be able to test and kind of see what the next process is. Warning, the next one's a little bit bigger. This is as far as I'm going to go, but this is something that has turned into cancer. So you can see how it starts out small and it continues to divide. And again, colon cancer is one of the slower growing. So that's why we have, there's sometimes quite a bit of time in between when you have to get your scopes. But this can happen over, depending on the literature, anywhere from 18 months at the fastest to sometimes 10 years before these morph into something much, much bigger. But there is hope. There's always hope. Colon cancer is preventable, it's treatable, and it's beatable. There are multiple modalities that we use once you are diagnosed with colon cancer. Sometimes surgery alone is enough to go ahead and cure you of that disease. Again, it all depends on how many layers of tissue muscle this has gone into. So again, right now they're saying around 50% of people who are found to have it can be cured just with surgery alone. It depends on kind of the features of your final pathology, meaning how deep did it go? Were any lymph nodes affected? Were the margins clear? Meaning, was there anything even close to the cells that were malignant that could have been left behind? So a lot of things would kind of determine that or not. But again, this can be, if caught early, it's very, very treatable. And then how do you lower your risk? We go back to kind of things that you can control. Talk with your healthcare provider about screening. Again, if we can remove the polyps early to prevent them from becoming cancer, then that's really our biggest win, our biggest availability. Exercising regularly, again, 3 times a week, 150 minutes is what's recommended, but it's one of those where the more you do, the better. So exercising at all, if you haven't been exercising, is of benefit. Maintaining a healthy body weight, not smoking or abusing alcohol, and again, their definition for alcohol abuse is more than 1 drink a day for women, more than 2 drinks a day for men. And then last but not least, again, issues with your diet that Sweet Sarah will talk to you about now. Thank you for your time.
So we could go on and on about nutrition for quite some time, but this is the very broad, healthy basics about nutrition that I'm going to focus on. But just starting with a quick statistic, it's estimated that 20% of cancers diagnosed in the United States are related to things those controllable risk factors. So 20% of these cancers are preventable, including colon cancer. So as Christy talked about, I'm kind of reiterating. There are a few things that we'll reiterate, but it doesn't hurt. These are those controllable risk factors for colon cancer. Overweight and obesity, as she said, so I'm sure most of you are familiar with BMI. The calculation is listed here. I should also note I do have printouts for you guys if you didn't get them before. All of my slides are printed in a very plain and boring handout, but you will have the information that you guys can take home. But a BMI of greater than 25 using this calculation is considered overweight, and then a BMI greater of 30 is considered obese. So staying at a healthy body weight is one way to prevent colon cancer. I will note BMI is a great use. We use it frequently of telling body composition, but it only is going off of your height and weight. It's not going off of muscle mass or anything like that. So there are some things about it that aren't so great, but it is a great measure. It's easy to measure and typically pretty accurate. Physical inactivity, smoking, and then heavy alcohol use. So those are all those controllable risk factors. So nutrition-wise, where do we begin? Like how do we start? So I'm just going to briefly go through exactly where to start on a healthy diet. We'll go through each food group. I have a list of recommended versus not recommended foods for you, and I'm sure you guys will have questions at the end, which is fine. So a healthy balanced diet. This is the Choose My Plate. I know it looks like a kid's printout. That was built that way. The idea is that it's very simple, easy to remember, easy to read, easy to understand. This is an ideal plate of 50% being of fruits and vegetables, and then a smaller, only a fourth of your plate being protein and a fourth being grains. But it's suggested of 4 to 6 smaller meals a day. So 3 meals plus, 2 small snacks or something throughout the day. Consisting of lean protein sources, low-fat dairy products, fruits and vegetables, and then whole grains. And then fiber, as we know, is always important, and then water consumption, of course. So for lean protein, the biggest takeaway on lean protein sources, try to consume lean sources at least 5 to 7 days out of the week, or 5 out of 7 days of the week. So that would be those red and fatty meats that we love, having those only 2 times per week. So here's a list of those recommended foods. It's going to be the things that you think of lean protein sources: turkey, chicken without skin, eggs, hummus, beans, peas, and lentils are good sources of protein. All of those things, nuts, nut butters, that kind of thing. Whereas not recommended, of course, we want to pick leaner options most of the time. That would include when you're shopping at the store looking for greater, I usually say greater than 90% lean, or 90% or greater of lean to fat ratio when we're looking at ground beef or ground turkey, that kind of thing. Processed and deli meats are usually fattier. They also are high in sodium. So, and then fried meats, of course. Fruits and vegetables, we want to aim ideally for 5 servings a day combined, or 2.5 cups per day. Recommended, of course, fresh, frozen, canned is just fine. When you're looking at frozen fruit, we want to look at the ingredients and make sure that the ingredient, let's say we're buying frozen Brussels sprouts, we want the only ingredient on there to be Brussels sprouts. But frozen has the same nutritional value for the most part as fresh does, so especially when things aren't in season or they're not so great, frozen is wonderful. And then canned, you want to look for fruit being canned, or veggies, you want to look for water or 100% fruit juice if it's fruit, and then you want to look for low sodium options if it's vegetables. So they love pouring salt into, it's a wonderful preservative, and they love putting that into canned vegetables, so that's always something to monitor. So obviously not recommended are any fruits and vegetables, mainly fruits that are put in desserts or pastries, adding sugar, fat, sauces to them. You know, broccoli is wonderful. People love it with a whole lot of cheese on top, melted processed cheese on top. So that would be under the not recommend. For whole grains, so make half of all your grains in a day. Whole grains is the biggest takeaway with whole grains. That would be like when you're shopping for bread, always looking for 100% whole wheat as the first ingredient. That's the biggest key. Consumers, we are consumers, and we are easily tricked when shopping at the store, and you'll see things that say whole grain or whole wheat or something like that. And if you look at the ingredients label, it will actually be the second or third ingredient. We want to look for the very first ingredient to be 100% whole wheat. Other options, or other things you want to look at when looking at bread would be low in sugar. They love adding sugar to bread, so that's one. And then saturated fat, sodium, they also love to add to grain products. But this could be breakfast cereals. You can look, and this is also where we'll get a lot of our fiber too, from these 100% whole wheat products, and we'll touch on fiber in a little bit. Brown and wild rice before white rice, oats and quinoa are all good options. And then we want to avoid the sugar-sweetened cereals, snack crackers. There are some that are great options. Always looking at the nutrition label is great, looking for ones that are low or no sugar added in those. White breads, pastries, biscuits, cookies, cakes, all those kind of things are the ones that are not as recommended. When we're talking dairy products, we're looking for at least 2 cups a day. 2 cups a day for adequate calcium and vitamin D. But when we're looking at dairy products, of course, we want to pick low fat or fat free. So any of the not recommended would be those made from whole milk products or cream cheese or any of the processed cheeses that you see. So if it says on the package processed cheese product, that's not the dairy that is ideal, and it might not even be much dairy at all. So you want to look for ones that are 1% or fat-free, made from 1% or fat-free milk. If we're talking cheeses, stick with skim milk or 1% or 0.5%. A common misconception is that vitamin D milk has the most vitamin D. I don't know if you guys know, vitamin D and whole milk are one and the same, and all milk has the same calcium and same vitamin D content. They call it vitamin D for whatever reason, but all milk, the only thing they're changing is the fat content. So drinking skim milk as opposed to vitamin D, you're not getting any more or less vitamin D. And then low-fat cottage cheese, low-fat yogurt. Fruit-flavored yogurt is just fine. You just want to look at the ingredients, take a look. I try to stay within, I usually tell my patients stay within single digits on the grams of sugar per like an 8-ounce thing. And that might be natural fruit that's added, but we don't want the added sugar or syrup that we sometimes get in fruit flavored yogurt. Yogurt's a great dairy option as well. So the fiber recommendation for adults is 25 to 30 grams a day. Most of that is coming from fresh fruits and vegetables, especially ones that have skin, so the peeling apples, pears, those kind of things. Fresh fruit and vegetables are going to have a little more fiber than cooked. Cooked is still okay. Canned is going to have the least amount. As you know, if you're getting something like a canned peach is pretty soft and does not have the peeling where a lot of the fiber is coming from. But that's they're usually very high in fiber, fresh fruits and vegetables, and then beans and peas, black beans, kidney beans, those kind of things. And then of course water. The recommendation, as we probably all know, is 8 cups a day of water, or 64 ounces of fluid with half being decaffeinated. So plain water is always ideal. Easier said than done. So the next best thing would be low or no calorie flavorings added to some of your water. Wouldn't hurt. I'm not a huge soda fan, but if you're going to have a soda, which is okay, of course, in moderation, I would pick diet before regular because we're talking sugar sweetened beverages. So pay attention to those and avoid those sugar sweetened beverages. And the main reason for that is maintaining a healthy body weight. So that's just added sugar in our day. That's just not what we want.
Back on the last slide, you said
sure.
half of the water being caffeinated?
Half of your fluids. So over fluids in general. I know I have water as the thing, but if we're talking fluids throughout the day, half of them being decaffeinated. So let's say you have a cup of coffee in the morning. We don't want more than 32 ounces to be of our fluids to be caffeinated. So caffeine is actually a diuretic, so it can increase our water expulsion. So it can increase the times that we're using the restroom throughout the day, so it can actually be dehydrating to us if we have it in excess amounts. So that's why our fluid consumption as a whole. Now, if I were up here, if we could all be perfect, I would say drink plain water 64 ounces a day at least, but I know that that's not realistic, so that's why, of course, the recommendation is 64 ounces of water. I know that that's not going to happen, but decaffeinated fluids, so let's say tea, for example, an herbal tea will count as your total fluid intake. It's not caffeinated, so does that make sense?
Less caffeination?
Yes, you don't.
At least half being caffeinated.
Oh, I'm so sorry. That should be decaffeinated. I read and reread this and never caught that. Thank you.
She actually works for Starbucks. She's trying to sell coffee.
Yeah, I'm like, can you actually continue to drink caffeinated? Sorry. Does everyone understand what I'm trying to say? Okay. Sorry about that. So as Christy mentioned, increasing physical activity. The minimum recommendation is 30 minutes 3 times a week or 150 minutes of moderate activity. That would be like a brisk walk. So I said 30 minutes 5 times a week. Of course, that's ideal, which would end up being 150 minutes. But like Christy mentioned, start wherever you are. So I always say anything is better than nothing. So if you do no physical activity and you can get out and walk 1 day a week, great. Start there, and then we work up to the recommendation. And if it's 10 minutes 3 times throughout the day to get to that 30 minutes, then fine. They suggest no more than, or no less than 10 minutes at a time, so 10-minute increments to get your heart rate up. But if it's 10 minutes walk in the morning, 10 minutes at lunch, and 10 minutes in the evening, that's your half an hour, and that's wonderful. Another way to increase physical activity or decrease physical inactivity would be reducing screen time just in general. So if we're not sitting in front of the TV or laying on the couch on our phones, typically we're burning more calories, whatever we're doing. So just reducing screen time. They really say less than 2 hours a day, which I know, seems like an impossible task. And then active alternatives to daily tasks, so parking out further in the parking lot and walking in, or taking the stairs instead of the elevator, or standing at your desk if that's possible, or moving around your office instead of sitting, if you have a desk job, sitting at your desk all day. They even say sitting on a yoga ball is kind of burns more calories than just sitting in our desk chair. So all of those are options just to increase things we're doing every day, but they do burn more calories by the end of the day. And then Christy also mentioned alcohol use. I just have this fancy picture here of what counts as 1 serving or what counts as 2 servings for men, you lucky guys. So of course with alcohol, moderation is key. So males 1 to 2 drinks a day, females 1 drink a day. And so then for liquor would be 1.5 ounces or about a shot or so. Then 5 ounces of wine, and then 12 ounces of a beer. And then these are just some resources that I used, and then also that have so much more information and go into more specifics than I had time to give you guys. So like I said, this was very broad. We're talking just nutrition, and we could go on and on about reading nutrition facts labels and sodium recommendations and specific numbers all day. But starting here usually is, of course, a start, and then with exercise compounded to a healthy diet, we reach that healthy body weight, which is the main goal. What I did not mention is I was talking colon cancer specifically, but this could go across the board. This is cancer prevention in general for the most part. So preventing all cancers, the risk factors are going to be a lot the same, and the way to achieve a healthy body weight is going to be the same as well. And that is it. Thank you.
I'm Deborah Tannehill. I'm a nurse practitioner, graduated from Purdue right here years ago. I've been working with Lutheran's gastroenterology department for the past 7 years, and I'm one of those lucky people that loves my job, so love what I do. When it comes to, well, first, our doctors bought all of us in the office these colon cancer awareness t-shirts, so I thought this was a great place to wear it. When it comes to screening colonoscopies, my role often is, after you've had your colonoscopy, if they did remove a polyp, to have you come back into the office, and we can look at pictures of it on the computer screen if that's a desire. We'll look at the pathology report. What kind of polyp is this? Is it just a little hyperplastic polyp that doesn't ever turn into colon cancer? Was it an adenomatous polyp, the ones that can turn into colon cancer? And from there we determine, when do you need to come back and have another colonoscopy? So family history plays a role in that, personal history plays a role in that, so that's my role there. If patients come into the office and we're talking about something else, and oh, you're 53 years old, did you ever have a colonoscopy? And they say no, then we can talk about the benefits and risks of a colonoscopy. The worst part of a colonoscopy is the prep. I don't know if anybody in here has ever had a colonoscopy. It's not very much fun, that prep. The day before is clear liquids. Take some Dulcolax tablets that get your colon started. Drink some whatever, there's lots of concoctions out there. We use a lot of Miralax and Gatorade till your poop is clear. And the reason is, Christy showed you some pictures of some polyps, and there wasn't stool in the colon. You could see very well, and that's what the physician needs when he's looking in your colon, to be able to see things. So the prep's not so much fun. Colonoscopy itself, you're asleep for. It's not too big of a deal. And most people afterwards feel pretty good. They're all empty, and then they can go out and eat breakfast. We talked about the average start date for colonoscopies. Then when do you quit doing them? There are agencies out there that have guidelines that say at age 75 you don't have to do anymore. But there's a lot of people that live to be in their mid-90s and are quite healthy. So we often just go by health. If you're in really good health and you've had polyps, the pathway from a little polyp to cancer is usually around 10 years. So every 5 years, if you've had polyps, we do another colonoscopy. So health really plays a role in when we stop doing colonoscopies. At our office, you can call and schedule your own colonoscopy if you want to, if your insurance lets you do that. And what else? I was going to talk about some of the other if you don't want to have a colonoscopy, and there are those people out there that's like, my neighbor's cousin had a colonoscopy and died, I'm never doing that. That's pretty rare. It's possible. Out of every 1,000 colonoscopies, there may be 1 or 2 things that don't go so well. There are other options, but they're not really very good options. The CT, it's a CT scan, CT colonography. You have to do the prep, the worst part. You have to have a CT scan with radiation and cost, and if they find polyps, you have to have a colonoscopy to get rid of them. So there's that. The Cologuard that she talked about, that is you have to collect your entire poop, put it in a container, send it back. I think the lab's in Minnesota or Wisconsin. And if they find advanced cancer, or they find cancer, let me put it that way, big polyps and whatnot, still you need to have a colonoscopy. There is the blood test that shows you've got some blood in your stool, and you need to figure out why that often. You'll get a colonoscopy for that. I think that's kind of the main topics I wanted to cover. We have some pins for you in the back if you want a colon awareness pin. I have some swag for you. And I would like to know if anybody have questions. Anything we can discuss or didn't cover that you were wondering about?
So is there any benefit to special diets like plant-based or gluten-free if you don't have, like, celiac or any other issues, or Atkins or any of these other diets in cancer prevention, specifically colon cancer prevention?
So a plant-based diet is mostly, without calling it a plant-based diet, what is a healthy balanced diet. So they suggest, when I showed you that My Plate thing, having the protein source, if it's a meat source, having it be a smaller portion than us Americans are used to is the basis of a plant-based diet. So having those fruits and vegetables, beans, peas, and legumes, having different protein sources, and then having those as our main sources during our meal, having those as our main portion is what's suggested with a little bit of meat. But a plant-based diet isn't a vegetarian diet. I don't know, just throwing that out there if anyone was putting them hand in hand. It's just suggesting that it's more plant-based. We're having more plant sources than we are meat sources like us Americans love. Gluten-free, there is no research, or other gluten-free, Atkins, paleo, those other diets that are out there are considered fad diets unless you have like a celiac disease diagnosis where our bodies cannot digest and absorb gluten as they should. Otherwise, there is no research to suggest that those are beneficial in cancer prevention. Mm-hmm.
I think I have 2 questions. As far as if you have a family history and you get the colonoscopy, is the Cologuard something that you would do in a year where you didn't get a colonoscopy? How often are you getting them if there's a family history? Like every year, or?
Cologuard is every 3 years. And colonoscopies, depending on what was found, if you have a family history of colon polyps or colon cancer, every 5 years at a minimum. If they did your colonoscopy and found 3 or 4 polyps, then you would need another one in 3 years. So it kind of depends on what you find.
And the age, if you've never had a colonoscopy, my mom claims she shouldn't get one now because she is 77, but she's never had one.
Yeah, she needs one.
Can you re-explain the polyps, how they form or can start in a person?
How they start in a person? Gosh, that's a good question. It's
good, then you
I don't know that I know the answer to that. Genetics lets us just start growing extra tissue. They talked about some of the risk factors for the
and getting a polyp, then
the inflammation.
The cancer starts because things have gotten caught in there in the polyp?
No, it's a change in the tissue. So they start off as adenomas it's tissue that's glandular tissue, and the abnormal growth starts in the tissue, and the ones that turn into cancer start off as adenomatous polyps. And they might be on a little stalk or they might be flat. And so if you just leave them sit there, the pathway goes from adenoma over time to carcinoma, which is cancer. And that's a very slow path. It takes years. That's why we can go 5 years between colonoscopies, or 10 if they don't find anything. Does that answer any of that?
I think family history has a lot to do with it.
Absolutely. Absolutely.
My mother's diagnosed with diverticulosis.
Yes.
Is that one of the precursors?
It is not. Let me show you. I forgot to get this out. I love this. So this, I don't know if you can see it in the back so good, but it's kind of our GI tract. Our doctors, when they do colonoscopies, enter and go up the, all doctors, not our doctors, up the left side, across the middle, down the right side, and into the end of the small bowel a little bit. These little pockets that form here, those are diverticula pouches. Genetics lets you get those. Diet plays a role in that too. They, in the third world countries where they still eat all the roughage and not processed foods, they don't have so many, but as they become more industrialized and start eating more processed foods, they start seeing more of these. Colon's like big bulky poops, so they don't have to squeeze so hard to move it along in our processed diets. Colon may have to work a little longer, and these little pouches form along some of the lines in the colon. And so it's possible that polyps hide in there, but it's not common. That doesn't play a role in colon cancer having diverticulosis. They get inflamed and infected when poop gets stuck in them. That's called diverticulitis. So there you go. Does that answer your question?
Yeah, it does.
Okay.
When you have the colonoscopy, are they also checking for rectal cancer at that time? I just want to.
Yes.
Yeah, they do an external exam as well.
Okay, because I've been asleep and I guess just.
Yeah. Yeah, because sometimes they'll find sometimes they'll find warts and things that warts or growths or something. They always biopsy that stuff, and so yeah.
Yeah, so the same camera that looks at the colon looks as they're pulling out. They're looking at the entire rectum as well. And if they see any abnormalities, they would take tissue samples at that time as well. Yep.
So what does family history mean? History with colon cancer, family members with colon cancer, or some kind of predisposition? I mean, polyps that are often removed, or do you understand my question?
Yeah, well, I think so. So colon cancer or polyps in the family, if it's first degree relatives, mom, dad, sister, brother, child, the period of time when you need to have another colonoscopy is usually 5 years.
So polyps are included
Yes.
in family history,
Yes.
not just the cancer.
Polyps also. That also plays a role in when you get your first colonoscopy.
Yeah, if you could address that, what is the age recommendation if colon cancer is in the family?
It's at age 50 for everybody, African Americans 45, but it also depends when the family member was diagnosed. If they were 70 when they were diagnosed with colon cancer, some guidelines say you should start at 40, others at 50, but if the person who had colon cancer, colon polyps was 54, you should start 10 years before their diagnoses, or even at age 40, some guidelines. Same with polyps.
What is your best convincing argument or persuasion statement to get somebody who's nervous about it? I just recently had a friend who was so anxious about having the colonoscopy they had to delay it because his blood pressure went up so high. But especially it seems like to me, men have an even greater resistance to it. So how do you overcome someone's objections to something like a
I haven't
colonoscopy?
met the person yet that wants to have a colonoscopy.
No.
So I haven't met them yet. But that person, we might have them come in the office and just kind of talk about it, answer their questions, explain what's going to happen. You know, if they're like that, you can't get them in the door. Every once in a while, somebody will need some Valium or something to get them in the door. But just explaining what's going to happen, what to expect, you know, the risks and the benefits, that type of thing would be the most helpful. Have you seen the billboards around town? I met the gentleman that paid for those. His wife died of colon cancer because she never had a colonoscopy, and he just wants people, you know, nobody wants to do it. It's not that much fun, but, you know, it can help prevent a cancer or even worse, a death. So there's that to think about.
And I think also it's just, you know, communicating just that this is a preventable thing. There are cancers that we don't have screenings for, that you can't do anything to prevent them because we don't have a screening test for them. This is something actually that there is a screening test for. So the fact that this is something that you do have control over. There are a lot of things in our lives we can't control. It's just luck of the draw. It's just the body's way. I mean, things happen. But this is something that you actually have some control over. And sometimes it's a whole, you know, you have to play that card sometimes, is do it for your kids. Do it for, we want you to be around. We want you to be here. And you're important to us. And this is an inconvenient day. An inconvenient day. But it could mean that we get you for 20, 30 more years. So it's kind of one of those of just saying, you know, and we have in the back, we have all the literature, like the things that we've talked about today, written down. We also have tips and tricks for taking the preps. I mean, there are things you can do to make that a little bit less. You know, if you have to have it with no warning, then it's liquid dynamite. But if you know it's coming, you can plan accordingly. You can change your diet a little bit so it's not as difficult. There are things that you can do, again, making good choices. There are tips you can do to kind of make that day not quite as bad. So again, it's more just, you know, explaining that this is really beneficial, and it really is scientifically proven to be that if you have this done and we find something, then you have a lot more options when we can remove it than when it has advanced. Your options greatly decrease the longer this goes unchecked.
And the rate of colon cancer in America is declining simply because we're doing the colonoscopies and removing the polyps before they grow into cancer. But to your person, I mean, I've met the people, they are not going to have a colonoscopy. They're not going to do it. I can't talk them into it. You know, I try and whatever. And then certainly there's Cologuard and other things that should be done if that's all we can get.
I have a sister-in-law who's what we would qualify as a health nut, and she gets high colon irrigations about monthly, thinking that that's going to prevent colon cancer.
The absence of poop does not prevent colon cancer.
No, and interesting, if you really start delving into details for women, especially older women, a lot of the colon cancers are on the right side of their colon. She's not probably, I mean, I don't know what a high colon, but you know, no.
In that regard, you know, Sarah, what would you recommend as far as if somebody asked you about colon cleanses? Are there any that are helpful?
No. So, well, to be honest, I've never been asked about colon cleanses. The most I get are cleanses that are usually regarding weight loss, quick weight loss, and those I usually advise against. But no one has honestly asked me, and I don't know that I'd recommend one per se. I don't know that there's any benefit that I know of to doing something like that.
For Sarah, again, another diet question. So would your answer be the same for like an Ayurvedic cleanse? You know, a lot of yoga studios want you to do a 3 or 7 day cleanse in the spring and in the fall. Is that the same answer?
Yes, and I don't know. That's not what our education is on, so I cannot claim to be an expert. I can hardly claim to be an expert on what I'm doing every day, let alone that. But I don't know the answer to that. But I would say, if I had to give you an answer, I would say it's the same.
Christy, could you talk about the Lutheran Hospital Cancer Resource Center and types of programs and services you offer?
Absolutely. Absolutely. And in addition to that, also, we will have a sign-up sheet that if you want to be contacted by the colon cancer clinic to see about possibly scheduling a screening colonoscopy, we'll have that sign-up sheet as well. The Cancer Resource Center is located attached to Lutheran Hospital. It's in the same medical office building that the Fort Wayne Medical Oncology and Hematology office is. So that exists kind of just to help people through the process. They've been there for over 20 years. It's kind of like a more homey environment. So when you walk in, Vera Bradley has kindly helped decorate. So it's got pretty wallpaper, it's tables, chairs, it's like more of a home environment. We don't want you to feel like everything is medical and sterile and hospital. It's more of being able to sit around a table with your family or sit on a couch and kind of discuss things. So the ladies who are there are all certified oncology nurses. They do help with teaching for chemo teaching, but there's also multiple resources, reading materials that can be checked out at no charge for anyone. So even if you have a friend who's going through this and they would like resources, you know, what can you say to them? Dietary cookbooks, that kind of stuff. There's all kinds of different self-help, spiritual books, just resources like that. There's also, they have yoga there for cancer patients on Tuesdays and Thursdays. Jennifer, who works over in Fort Wayne Medical Oncology and Hematology, teaches that class and just kind of healthy things. Also, we have our sweet dietitian who comes and does personal counseling with patients there. We have just an area that's kind of a safe area that questions. Sometimes it's family members who have concerns. It's, I don't know what to say. I don't know, you know, how do I interpret this information? Kind of knowing the internet is great and there's a lot of information. However, anybody can put information on the internet and say that they're a physician or say that they're a healthcare provider or say that this cleanse is the best one. So it's being able to navigate which one of those the doctors really trust, which ones are certified by true clinicians. So kind of knowing which ones, again, American Cancer Society is a fantastic resource for anything. I know a lot of our oncologists practice with the NCCN, which is the National Comprehensive Cancer Network. So basically it's, you know, if you are a certified oncologist, it gives really like algorithms for if this type of cancer is found at this point, then kind of what treatments are, so that you know that people are really not just guessing about a treatment, but they really know that this is the proven things. We do a lot of clinical trials. So it just being able to kind of be able to see what the community resources available are, being able to plug people into, even if they're not in Allen County and surrounding areas have cancer services, which is a fantastic resource. Making sure they get plugged into that. Again, our oncology office has their own person who even cancer services goes there, but just making sure people are connected with the support that they need, with the resources they need, with the education they need, because the more you know about your health, the more you know about the process, the more confidence you have, the less anxiety you have. Again, just trying to help people through this process. This is what's going to happen next. This is why this process takes time. Kind of explaining why does it take 2 weeks to get an appointment? Well, again, there are processes, testing that has to happen so that we can make good treatment plans based on all the education of what's going on with your body. So that's some of the things that we do there. There are more, but I can't necessarily remember them when I'm being looked at. So, but just so you know that while she was speaking, I did think of a song that I should have burst into, rolling, rolling, rolling down the colon. So I'm just, you know, I do burst into song. But no, just to know that there are people that are there to help you through the process if this does happen, because no one wants to hear those words. But again, that there are people there to help you through, to love you through it, and just make sure that you have all the education and support that you need to make good decisions and to keep going. Are there any other questions? Another song request? Okay.
Okay, I'm right here.
My husband and I see Parkview doctor. I mean, our primary care is Parkview, and so we have current orders for colonoscopies. Do we have to stick with the Parkview, or can we interchange to the?
I know that typically it's an insurance issue, so that would be something you would ask your insurance. Some insurances do allow people to go either place, and some have preferred providers where their coverage is greater at one facility than the other. So definitely check with your provider to see if it is going to be covered at the same amount each place.
We have one provider who And one last thing I forgot to say, do you know that when you have a colonoscopy, you're asleep for that? You're sedated. Okay. I thought that, oh yeah, make sure everybody knows that.
Well, thank you, Christy, Sarah, Deb. Thank you so much for the information that you've shared today. Excellent, excellent information. And our hope is that everybody walks away with some thoughts and ideas that you can apply to your own personal life. So we enjoy getting feedback because it'll help us plan forward for future presentations. So before you leave today, please fill out your evaluation and then just leave it at the back table. And again, thank you, Christy, Sarah, Deb, for being here. Let's give a round of applause.